Welcome, everybody. I'm Nancy Fritch, and I'm the course advisor. And thanks to MCAT, who's filming the TV and who's filming the presentations. They'll be available in about a month, and I've already seen some of them. They're excellent. Thank you very much, MCAT. I'm going to introduce Dr. John Miller. He's almost a native. He's from Wallace, Idaho. He graduated from the University of Washington WWAMI program in 2000. And after completing his family medicine residency in Tacoma, Washington, he lived and worked for 8 years for the Indian Health Service in Zuni, New Mexico. For the past 5 years, he's been medical director at Partnership Health Center in Missoula's Community Health Center, which runs a clinic for the Paparella Homeless Shelter. He's also clinical director for the new family medicine residency program in Missoula, and he supervises the clinical activities of 40 residents who are getting their training there. So we're very happy to have John here tonight. I think even though this is global health, there's a lot of global health home in the U.S. where you see a lot of people from different backgrounds and cultures, and I think that's very relevant to the topic he's talking about tonight. Thank you.
All right, thanks a lot, Nancy. I appreciate it. Yeah, that was going to be the first thing I said is, why are we talking about Montana as a global health class? But we'll get to some of that. So as she mentioned, I work for a Partnership Health Center, as well as for the residency program, which I actually helped found, and we're graduating our first class in July, so it's a real accomplishment for us. We're very excited about where our graduates are going to practice. Of course, I'm having the same problem as everybody else, so I'm just going to push the buttons, all right? So first of all, I think the key thing is, let's step back for a second and look at the definition of global health. I think it's important just to understand that some of the health problems and issues, they transcend national boundaries. They're issues, they may seem like more important issues abroad or at home, depending on your perspective. But really, when we talk about global health or local global health issues, there's some of these issues that transcend boundaries and are particular interests for those of us who work and care for underserved patients, particularly here in Montana. Also talking about not just providing care, but also public health, trying to reach broader populations, looking at some of the social determinants of health. That's what I aim to do. I did it last year, and they still let me come back this year, so we're hopeful that it will go well. Just talk to me a little bit about global health factors. I don't know if anybody's gone over this yet, but I think it's important to think about what are some of the things that create health problems. So there's predispositions. So there are some genetic factors related to racial and ethnic considerations like susceptibility to malaria. Maybe somebody mentioned that, but there are some African populations who, because they're actually protected against malaria by a sickle cell trait, they are more likely to get sickle cell in the United States or elsewhere. So that's kind of an interesting racial issue that is predisposing. Gender and age, there are certain things that target women, children, geographic location. Rural issues, there's a lot about that, not necessarily around genetics, but more maybe around the social issues, some of the economic factors, social and economic factors that are present in more rural areas where people have fewer resources. Then there's enabling factors, so things that actually help you do better or less likely to have health problems. So healthcare access is kind of a key thing for the uninsured. And I think last year we were talking a little bit about Medicaid expansion and what that was going to be. We're now seeing our first people getting enrolled in Medicaid expansion. So folks who were previously uninsured now have insurance. You know, it's not like a broad swath to get everybody on. People have to sign up. They have to pay part of their share, but We are seeing a lot more people with health insurance, which is useful. And then some of the enabling also is if people have problems with their home environments, food scarcity, poverty. These are things that, if you don't have these problems, you're less likely to have health problems than if you do, and that's kind of where I'm going to focus today. And then there's particular needs in other areas. So here's another way to think about this, is it just in terms of factors that affect health. I think we're hopefully in this we're talking a lot about, in this course, we're talking a lot about socioeconomic factors. Then there's kind of the context in which people live, making healthy decisions, kind of moving up to clinical interventions. I think Tom Bolger talked about the fact that actually clinical decision making is a really small part of the health advances in the last 100 years. And then getting into some of the habits or healthy lifestyles that I think in Western medicine we spend a lot of time talking about, and ultimately can make a big impact if people make big changes. But overall, it's some of these other things that really lay the groundwork for people's health. So just to step back for a second and talk about Partnership Health Center. It's a community health center here in Missoula. There's about 15, 16, I should know the number, but community health centers in the state tend to be in larger towns. So Kalispell, Butte, Helena, the usual places you'd expect. So we're aimed at ensuring access to comprehensive health care and meeting the needs of our region. And so part of our initiative on this was when there was a need in the homeless shelter for us to provide care for those patients, we applied for a Healthcare for the Homeless grant. This is a long time before I was there, but had a little one-room clinic in the old Poverello building. And when the new Poverello was built, they said, okay, yeah, let's get 2 exam rooms. Let's make this more functional as a clinic. And so we've been there along the way to try to help provide care for the homeless population here in Missoula. So this is the new building at the Poverello. I don't know if any of you have been there, but it's actually really beautiful, and there's great services there. We'll talk a little bit about the services there, but just to mention also that we have the clinic there, and there are great volunteer opportunities that I'll end with a slide talking about how everyone here can get involved if you're interested. The mission for the residency program is a little bit different. So the health center is about providing access to care. The residency program is really about training the next generation of doctors who are going to be able to provide care in those settings. So there's good evidence that residents who are trained in community health centers are more likely to serve or see patients, go on to practice in rural and underserved settings. So that's why it was decided to have the residency program at Partnership, and it's looking like it's a success as the first class is signing on to their jobs. Several of them are going rural, and the majority will stay in in Montana. The mission, I love this picture. Sorry, it was one of the first days, and it was in the paper, so I'm putting it in everything. All right, I love this picture. So one of the things is really we are doing actually some really creative things around interprofessional education with the residency program, a lot around team building, trying to bridge some of the issues between how's healthcare different in rural areas compared to urban areas, and really providing resources, providing the residents exposure to those teaching opportunities, and so far so good. So I want to start as we shift to homelessness to talk a little bit about the myths of homelessness. I found this article from the LA Times just recently, and I think we're all susceptible to this. I mean, I am. I work in community health, and I'm still susceptible to these things. I think this idea of people choose to live on the streets, particularly maybe the more chronic homeless, people who have been on the streets for months at a time, you look at their choices, and it can be kind of hard to see how they're not choosing to live on the streets. But I think some of that ends up making us a little bit less sensitive to some of their problems and the ways that we could help. This is a really, second point is really interesting, this idea that people choose to live based on services. So I think there's a lot said about Missoula in this way. Part of why we have so many homeless in Missoula is because we have so many services. And they're talking about this in the context of LA, where, oh, it's so beautiful in LA, that's why we have so many homeless in LA. But actually, homeless people are less likely to relocate than people who have houses and resources. So just like folks, I don't know, a lot of you probably here, I came to Missoula for college. You all are more likely to relocate than homeless people who have fewer resources to be able to do so. The next thing is most homeless people, most people are mentally ill. Sorry, I'll work on these slides. I'll make them better for the next time. But anyway, most homeless are mentally ill is what this is supposed to say. Sorry, extra point. Most people here are mentally ill. No, I mean, I think this is kind of a, it's not most, it's less than 50%. Are they more likely than the general population? Definitely more likely than the general population to become homeless. But homeless people are more likely to have their mental illness exacerbated and made worse by their housing insecurity or total lack of of having a home. And then this last point I think was just a good point to say homelessness is too expensive to solve. It's really expensive. We throw a ton of money at it. Because we're not trying to solve it maybe in the most comprehensive ways that we can. So really, when we get to that pyramid where we're talking about the social health factors, socioeconomic factors down at the bottom, our income disparities in this country are pretty extreme, and it ends up that a small fraction of the wealthiest have most of the resources. And so that leaves, when you're getting down to the working poor, unemployed, that they're just not dealing with many resources. And I think it's good just for us to keep this in mind. And so you're like saying, hey, this is obvious, you know. But 92% of Americans believe that the wealth distribution is more equitable than they think, okay? So here's the actual distribution of wealth with, you know, most of the income in this top 20%. But people, you know, think it's like this. They'd like it to be like this. So I just think it's worth bringing this up. The global distribution of wealth is even worse in the United States, and problems with homelessness and food insecurity are even worse in other parts of the country than in other parts of the world than in the United States also. This is kind of like different side. The pies mean different things. It's actually mind-boggling. The bottom 99% have just like a quarter of the resources. It's incredible. 99.9%, my goodness. So there is a reference on this that I didn't make it up, you know, kind of thing. I love maps, so we're going to see a lot of maps, okay? Just bear with me or enjoy it, however you want to think about it. So we live down here in Zuni, New Mexico. I know Nurse has already talked to you guys, so you probably know where it is on the map. But look at all this red, okay? We lived in an area with a lot of poverty. Indian reservations tend to be that way. Statistically, there is some Indian gaming that is kind of turning the tables on some of that. But that wasn't present where we were. And it's not present in a lot of the reservations in Montana. You can see some of the counties up there that are kind of wide swaths of red. Okay? What else to point out in here? I think the Deep South is kind of a key thing. So a lot of folks who are interested in working with underserved populations in the United States focus on the Deep South and also Tex-Mex, kind of El Norte. The kind of Mexican border is kind of a key place where there's a lot of poverty and very enriching work experiences possible for whatever you're going into. So there's plenty at home here in Montana, but also plenty at other places in the United States. So this is the percentage of people living in poverty areas by state. And so the reason I kind of decided to put this up is that we actually have a lot of poverty in Montana. Montana is a relatively poor state, a lot of working poor, and we'll get to that in a later slide. Just a kind of average job pays less in Montana. I guess we get paid less because we get to live here. I guess this is the way to think about it. You know, again, down south it's even worse, and then Texas and New Mexico. But you know, we have big issues here in Montana. I like this because I think one of our misconceptions about poverty is around, disability or people who don't work, and the proportion of the non-working poverty in the United States is smaller in proportion to the amount of poverty than in a lot of other industrialized countries in the world. I think the misconception is that people who are poor, it's because they don't work, or they're choosing not to work, or they're choosing to be homeless, or whatever. But actually, that's not the case in the United States compared to other places. The other thing is that there's a lot of working families living in poverty. So these are people in families where there's a wage earner. And if you look at the poverty line, 100% federal poverty line, I don't know if you guys have looked at those numbers. It's super low numbers for maybe a family of 3 or a family of 4. So really a good definition of poverty is 200% federal poverty level. And here you're getting into almost a third of working families live in poverty. Well, actually, between the two numbers together, almost half of working families live in poverty, if you broaden the definition of poverty to low income. Working poor occupations. I thought I put this in here just to say, like, what do the working poor do, And I think key things are service industry is kind of a big thing. What's this dark green? Retail, trade is kind of a big thing. Construction is this sliver right here. So there's certainly occupations that we're aware of where folks are more likely to have like a minimum wage, not a living wage sort of thing in certain occupations. So it's not that people aren't working. This is, again, gets at that previous slide, kind of a different way to see that previous slide of Montana having more poverty. We have more occupations that pay below the poverty level. So the wages have been stagnant in the state. And so even as costs increase, this is kind of an ongoing issue, another way to look at it. So I wanted to throw this up here. I suspect a lot of you have seen this, but I think it's good for us to remember, and I think Narissa talked about it in her talk in an interesting way, is that if you can't take care of the bottom of the pyramid, if you can't get your basic needs met, it's really hard to do the rest of these, okay? Okay, let me put my homelessness and poverty aside and get into self-actualization. It's hard, okay? Now there's ways in which people can find niches to be more safe or to find love and belonging. And you look at actually some people on the street, and I think is more abuse and more dysfunctional relationships on the street, but there are some couples who work very well together and help each other out and support each other. So some people are up here even as they're not in here. But I think it is more challenging to actualize in some of these higher levels when people are not having their basic needs met. How are we doing so far? You guys following me? All right, we got some thumbs up, some nodding off. No, I'm just kidding. All right. So this is really cool. I'm going to talk a little bit more about kind of the Housing and Urban Development's initiative to end homelessness, and I'll show you what the initiatives are on that. So there's been a big aim since 2010 when this bill was passed by early on in the Obama administration to try to end homelessness. I'll show you the definition of that. And overall in the United States, we have decreased homelessness by less than 0.5%. By state, you can see there's some states that are getting worse, some states that are getting better. And I would just want to say that Montana is getting worse. So I think I don't know how people feel about 2011 to 2012. We're kind of coming out of the recession maybe a little bit. The Bakken oil fields were revving up maybe. Some people were dislocated from Montana from western Montana over to eastern Montana, trying to find better paying jobs. So there was some of that there. So this, I think, tells the story about why New Mexico and Montana had higher homelessness over this time period. And that is that even in times of economic boom, people can be relatively marginal as working poor. and be insecure in their housing. So it's kind of a way to flip it that I wanted to spend 2 slides on. So there we go. All right. The next thing is levels of homelessness. So here's the HUD's definition. This is kind of what we think about in terms of some of these things. Let's see. So people sleeping outside, people who maybe are in an emergency shelter, which could be added here, and maybe traditional housing for the homeless. One of the things when I started working at Partnership that really I got insight into in the first couple of years are the people who are down here in this broader definition. Folks who, maybe are doubling up, they've had to move a lot. I actually heard a statistic, I'll just say it, I don't even know if it's true, but we started this first school-based health center at Lowell School. So it's a beautiful building over by Lowell School. They're going to tear down Lowell School and put it all up, and we're figuring out how to staff it and put it together. It's a cool part of our job is to try to put something like this together. One of the parts of the needs assessment that led to the grant application on this was that there was a class, I think it was a 3rd grade class, where at the start of the year and at the end of the year, they had 25 kids, and none of them were the same, okay? I don't even know if it's true, but if it's even close to true, that's mind-boggling. And I was told that it was true, so I can't personally confirm it, but I think a lot of the folks that we work with in community health have a lot of housing instability, where they're doubling up with, actually just today in clinic, I was talking to a patient who's having a lot of stress at home, and it really comes from her friend was staying with her in her room at the same time that her sister was forced back home with her mom, and she's living with her mom, and they're sharing rent, and it's just like creating a lot of stress down at the bottom of Maslow's hierarchy of needs, where the rest of her health is really hard to address. So my goal on that visit was to help her identify the issue is with the instability in the housing. So what can we do to help you problem solve around this so you can get that stable, so you can work on some of the things higher up in the hierarchy. So kind of interesting, at least to me. So next up, homelessness in America. This is another way to think about this, where we think about maybe the people at the top of that pyramid are the chronically homeless individuals, a really small piece. They get most of the media. If I were to show you a bunch of pictures of homeless people to capture the homeless feel, those would be the people who are in there. But it doesn't talk about the people who may be homeless on a given night, maybe experience homelessness during the year in a time that's kind of a transition or challenges, maybe financial or relationship-wise that people feel. Some people never have to move their home, but they live in squalor, places where you wouldn't want to live, and it's not stable. Like their floor's uneven, they could fall and hurt their ankle if they stepped in the wrong place or something like that. And then the idea of greater than 50% of your income goes to supporting housing. So this is a broader swath where people who have income, but housing is so expensive that people really have to put a lot of resources into it. Here's a slide that just talks about some of the homeless people in families and where they tend to live. So let me break this down here for a second. So you've got the total individuals are down at the bottom of this, and so they're sheltered and unsheltered. Well, let me see. So unsheltered individuals, and then here's the people with families. So I wanted to put this up mostly just to show you that about half of the people who are homeless by the HUD's definition, this is from the HUD slide set, are living in families, okay? And it's about maybe 67% are individuals. So it's or 63 and 37. Here's another look at it to say, what age categories we're talking about. So we're talking about kids who are homeless in these homeless with families. So among all homeless people, sheltered and unsheltered, it tends to be that people with families, young kids are more able to get into shelters, which seems like an appropriate thing to me. But overall, under 18 is almost a quarter of homeless people. Okay? So housing instability, just to give you the definition of housing instability: difficulty paying rent, greater than 50% household income, I was talking about that, frequent moves, living in overcrowded conditions, and doubling up with friends and relatives. So this just kind of gives you a broad of low-income adults. Over 40% have problems with food insecurity, and almost a quarter have housing instability. So this is a major problem. When you get into the frequency of homelessness by the HUD definition, you're looking more about 10% of people have problems. Low-income adults have problems with that. So doubling up, this is just showing that the trend for doubling up increased in the 2000s. This is really, in my opinion, this was about the recession where people were losing their homes. A lot of foreclosures during this time after the bubble burst and that kind of thing. So the economic conditions of the larger economy affect this kind of thing really significantly. So how does homelessness affect people so that they have more health problems? So poor nutrition, overcrowding, sleep deprivation. So like to get a good sleep, you really need to be secure and in a comfortable place. Violence abuse, I'm not sure where that came about. Yeah, sorry about that. But violence, sexual abuse, physical and emotional trauma, extreme weather exposure. So I think we're going to talk about some of this. So this is just looking at the percentage of total deaths among homeless people by their age, okay? So what happens is homeless people are more likely to die from different medical problems, exposures, violence, these kinds of things, suicide. We'll go into some of that. And what you have is a lot of young people, like, I'm 46, so I'm in this group. We're young, all right? Young and younger, all right? A lot of young people. Whereas you look at the general population where people die, this is a lot higher, and these would be a lot lower, all right? So it really, a lot of people who die at young ages where it's very sad that they, it's unexpected what you would expect. So when we talk about life expectancy, having premature deaths really moves the meter in terms of life expectancy. So if a child dies in a third world country, I don't know, I think it's developing nation now, but if that really skews the life expectancy. So that's how you get a shift in life expectancies from the 40s up to the 60s, 70s, even though people have a lot of problems with different health issues in developing nations. So this just says, like in the United States, close to home, we have a lot of these same problems. This is why I'm talking about this in a global health class. I think is the way to, this is what you might expect numbers-wise from a developing nation. So how does this happen? One place is diabetes control. Really hard to control diabetes with the different stressors. So this kind of dotted line is what you might expect from your clinic population of people who have homes. So there's just a lot fewer people in control and a lot more people who are what I call terribly out of control, okay? And a lot of this just has to do with homelessness in ways I'm about to talk to you about. Okay, so here's that. All right, well, we'll ignore this. I don't know how to put that off to the side. Oh, that's interesting. Maybe it's... Okay, so I tried to adapt this slide into kind of the key points that I thought were there. Let me escape this and get rid of this. I think you get extra points if you can get this to go away. But I may not be able to get it. Maybe I can move it, shrink it, drag it, get rid of it. Miller. Yeah. All right, so what does this say? All right, the key things, if you could try to ignore the red and get into the rest here. Let's see, this helps me know how I'm doing. Let me see. I'm doing okay time-wise. So limited control of diet, that's kind of a key issue. Where are people getting their food? What quality of food? Do they control the quality of their food and whether it's good for somebody with diabetes, this kind of thing. Insulin storage is a huge issue. This is a big issue on the reservation. I had a patient who had, first of all, had to drive like 20 miles on dirt roads to get to the hospital to come see me. And then I needed him to be on insulin, but he had no refrigerator. He had no electricity, much less refrigeration. So that made it hard. But imagine if someone's homeless. I mean, there's an issue of housing, really homelessness in that broader definition of people living in substandard housing. But anyway, so there's some medical things to talk about. Shelter food's a problem here. You want to use a longer acting insulin as kind of a thing for medical people to think about. Some of the side effects of medications can make it really problematic for people to take medications. So like metformin is kind of a problem for those who know medical stuff because it causes a lot of stomach upset, diarrhea, things like that. So people are unlikely to take it, and that's why so many people have diabetes that's out of control. Okay. Next up, talking about mental health, some of the issues here. I just thought this was fascinating. I wanted to throw this in here because this is really emblematic of the social changes in our country, okay? So 1963 to 2003, 40 years, really the mental hospitals, I know there's, like, I don't know, there's horrible movies about these kinds of things, and probably some of them were problematic and hard to be, but it gave people support, and that was a big issue. And where's that transfer into prison, homelessness, mental health is exacerbated by insecurity and often leads to homelessness, or homelessness exacerbates people's mental health problems. And then I think there's just a lot of impaired executive function. That's kind of fancy talk for people's decision making is not what you'd expect. And I think Narissa got into this a little bit, where people have scarcity problems, their IQ actually goes down, where you create too many problems for them that they're dealing with in their background is chatter. They can't sit down and focus on the most important things, or maybe less important things, because they're not those other things that are in their minds. So, mental health problems are a big issue. Substance abuse problems are a big issue in the homeless population. And homeless people have 5 times the rate of the general population in traumatic brain injury, the exposure to abuse, both while they're on the street, but also while they're homeless, and then also in the past as a cause of, kind of a factor that makes it more likely that they would become homeless. Suicide is much more common in homeless populations. That's part of the youth and people, the problem in youth and premature death. And so this is just kind of, these are the risk factors. These are things that make more likely. So if you're ever seeing a homeless person who has depression, is having a difficulty adjusting, seeming hopeless, these are things that should really tip you off and be concerned about the risk of suicide in those folks. Children in the homeless population, it says 1 in 3 homeless are people under the age of 18. It's actually 1 in 4, but we won't quibble with the nice sign in front of the church. And this was just, I think, a really cool slide about how poverty affects child health. And this also gets back to what we were just talking about, some of the issues there. So rundown housing puts people at risk for social isolation, violence, increased exposure to different pathogens or allergens, these kinds of things. Children living in poverty are at increased risk for lead poisoning, different things that really affect their brain and their ability to learn, some of those sorts of things. Children who are homeless or maybe are in more crowded conditions or otherwise have their immune system kind of held back by some of the challenges in their lives. So they're 4 times more likely to get sick than other children. And so compared to their peers, are more likely to have ear infections, stomach problems, or kind of stomach viruses, and to develop asthma. So this is kind of the way that some of that gets operationalized and occurs. And then exposure-related conditions, I mean, this is really kind of obvious when we think about it, that people don't have shelter, so they're exposed to extreme cold or extreme heat. And basically risk of death or serious morbidity or problems related to the exposure has to do with the absolute temperature kind of times the duration of the issue. So if you're exposed to very cold temperatures for a long period of time, this is, it can lead to death. It's pretty awful. Alcohol makes it worse. There's ways in which it works in the body to make it so that we're more susceptible to cold and heat injuries when we use alcohol. Poor nutrition is also a problem with this. And then they may have some underlying disease problem that makes it more likely for them to, maybe they're dehydrated from some medical problem or something like that. So this actually just made me think of one of the things is I lived on a dry reservation, so this was a place where people could not buy alcohol. The closest place where somebody could buy alcohol would be 15 miles. We could have alcohol in our houses, we just couldn't buy it on the, actually I'm not sure if we could, but anyway, people had alcohol in their houses. And we did, and we didn't have a problem with it, so it wasn't a big issue for us. But it was frequently that we would see somebody who was found down in the cold trying to get back from where they had gotten alcohol. So, I mean, it just makes it hard, some of these challenges. So anyway, this just talks a little bit about homeless hospital stays, and basically to say that down here, the uninsured folks who are homeless are more likely to have hospital stays related to heat and cold exposures than people who, have private insurance, Medicaid, Medicare, these kinds of things. It's kind of a big issue. So treatment guidelines, how do we intervene? How do we try to help? But one thing is interesting that I should share with you is I have never seen a patient at the Poverello Center, okay? I'm the medical director of the satellite clinic at the Poverello Center, but I'll admit I've never seen a patient there. But I have worked with many homeless people at PHC, folks who, because I ask about it and try to understand what the social conditions are that are kind of underlying the medical problems of people, I am aware of many of my patients who are homeless, have had housing instability at different times. So I say this at the same time, I've never seen a patient at the POV. We send our PAs, our physician assistants there, and they provide good care there. But the treatment guidelines, kind of our aim in having a clinic at the POV or healthcare for the homeless, our aim is to provide access to care. The things that really make a big difference is if we can transition people to stable housing. So we have a social worker on staff, full-time social worker that we hire to provide social work services in support of our PAs at the Poverello Center, helping them kind of get connected to the different supportive services. And ultimately, if we can get them to employment, these are the things that are really going to help people's health. And that's what we're going for. So talk a little bit about the goals to end homelessness. This is from a HUD report. And this is just kind of telling you what the goals that were set in 2010. So one is to prevent and end homelessness among veterans in 2015. We haven't done that. It's 2016. We have made a lot of progress in veterans. There's a lot of services available to veterans, but there's also a huge burden of some of the things that we've already talked about in terms of particularly mental health problems, substance abuse, that makes it hard to intervene and really get everybody out of homeless situations. The other is chronic homelessness, so people who are on the street for long durations. There's some strategies for that by 2017. Preventing homelessness for families and children and the youth in 2020. And then setting a path to ending all types of homelessness. So, I think these are good goals. I think we've scratched the surface, which is better than not trying at all. One of the transitions, and this is a very complicated slide, what I want you to focus in on is just this flip right here, okay? This is how a lot of people get benefit, okay? And that is a transition, a change in strategy in the 2000s from having shelters and transitional housing to more supported, how do they put it? PSH, what is PSH? I'm blanking on it right now, but something supported housing, provisionally, something. So anyway, the idea is to transition from more short-term, give somebody a roof over their head, give them a place to sleep for a night, to really trying to work with them to transition them into a supported housing environment. So this is the strategy here, is rapid rehousing. So identify what are the potential housing options for people in a certain situation, rent and move-in assistance to try to get them into a more, it's P is for permanent, of course, permanent supportive housing. So sorry about that. But yeah, trying to identify, get them moved in, and then try to do case management and support them to try to prevent loss of housing once they're in housing. And then if they do slip back into homelessness, try to get them back into permanent supportive housing, permanent stable housing, sorry. All of this had me reflecting about the, what do you call it? Rapid rehousing system that we had in Zuni, which was very cool. There was very little HUD definition homelessness in Zuni. Okay, there was a lot of down at the bottom where people were sharing and housing instability. That was definitely the case in Zuni. It's a very poor area. But they had a very cool traditional ceremony. It's called Shalako. And so what this is once a year, these groups of people, they're called kivas, they get together, very organized, and build somebody a house. And so there's 5 houses that are built every year, and in December, so it's kind of celebration of the harvest is I think where it evolved out of. I mean, I don't know, I'm an outsider, but that's the idea, is every December they build anywhere from 5 to 6 houses where their gods, the Shalakos, come and are seen and dance. So this is a picture of, one of us doctors peering through the window. We were allowed to kind of see in where people inside the house were celebrating, finishing this house, finishing the harvest, finishing a good year, this kind of thing. And the Shalako is being escorted by his 2 handlers. And so it's like this big bird-looking thing with this beak that kind of snap, and if a kid's like falling asleep, they'll go up and snap next to the kid and everybody laugh, this kind of thing. So the Shalakos are very cool, very beautiful things, and this is just an artistic rendition of it. You can't take a picture of a Shalako, it's against the rules, so I don't have any pictures. But I think this is, to build 5 houses a year is pretty impressive for a community of less than 10,000 people, and they've been doing this for ages. One of the things about this that kind of, I thought, created more housing instability is that people put all their resources into this, like tons of time, a lot of money, and then they'd be done. It's December 5th or whatever is the day for the Shalakos to come, and it would stop. So the house would get as far as it was until Shalako. So there were some places without siding, or like this one place that never got its siding up. It had the wrap on it, and it was like over the next 2 years, the wrap got further and further off, and then it's blowing in the wind, and I don't know, that was stressful for me to drive by and see that. I imagine it was stressful for them to live in there and be like, we almost got it done, but not quite, and the stress associated with that. But I think overall, it's a really cool program that probably they've done in a way to help as a society to address some of these issues where everybody has a roof over their head. This is a picture of Zuni Pueblo. Nurse might have shown a picture like this. This is the first skyscraper in the United States, all right? Forget New York City, okay? This is like 1000 AD kind of thing. 800 years ago, they had 4 or 5 stories stacked on top of each other for defensive purposes. Very cool. Right now, it's much more spread out. So this is like from 1910, 1920, when kind of the first Anglos came, and they took a lot of pictures, but there's not really modern pictures so much. So a lot of ladders, people working their way up, a lot of people living close together. Very interesting place. The Chalicos have races. They're not actually racing. They're planting prayer sticks. But they go out on this big riverbed, and the Pueblo is kind of on this other side. And so on this side, and no Anglos can be on this side during Chalico, unless you're in a house, which I did get invited once to be in a house. But I actually like the view better on the other side, and you can be outside and be more free, so it was good. But you look across the river, and so the Chalicos all parade through town, or from their houses out to the grounds, and they're kind of followed by their handlers, and they get out to this has nothing to do with housing, really, this is just sharing. And they have like this field, and they run back and forth and plant their prayer sticks. And so they run, and then they like stop, and something drops out, and then they run. It's very funny, and they think it's funny. They love it, this kind of thing. So the one thing is, if a Chalico falls, it's bad. Like, everybody just scatters. I'm told, it never happened when I was there, but I'm told that if a Chalico falls, it's because somebody didn't do their work or something like that, and their handlers will like go out in the crowd and beat people. That's what I've been told. All right, we're going to shift a little bit to food insecurity. That was a little bit about Zuni, but here we're back, okay? Food insecurity, I think, is related to homelessness in some important ways, and is a problem on its own, even for folks who have housing, secure housing. So this is just kind of a question. Back to maps, okay? So just looking at food insecurity rates in the United States. So Montana overall, I think it's 1 in 7 kids have food insecurity. So that would be like around 14% or something like that. That's as a state as a whole. But as you can see, there's counties where there's a lot of food insecurity in Montana, and down where we lived in, it's the Southwest and the Tex-Mex border and the South. It's related to the poverty that is related to homelessness as well. So this is the percentage of people on food stamps or SNAP benefits, and as you can see, it's a lot of the same areas, certain counties in Montana where that's particularly high. And let me just look at the legend here. So Montana overall is about 20% on food stamps. Food deserts, this is a really cool concept. I don't know if other people have heard about this, but some people live in places where it's like really hard to find food. It's really far. Or actually, you can get a picture of Chicago that's blown up. I used to live in Chicago, so I found it interesting, where it's actually kind of a long way to get to like a proper supermarket. You can find, fast food or these kinds of things, but to get to healthy food is actually more than a mile in some areas of Chicago. So anyway, a lot of the same issues here where there's issues. Here's kind of where more than half of the people, so in dark here, are counties where more than half of the people do not have convenient access to a supermarket or a super center in U.S. counties. So almost all of Montana, right? So you got, almost all of Montana. I thought this was very cool. So this actually shows you where you go. Like, if you're right here, this is where you go to find food. You go to Reno, basically. Or let's see, Montana up here. You get into some pretty far distances over in eastern Montana and up north along the High Line, where folks have a lot of distances to go. So how are we responding to this? So there's a lot about farm subsidies, like what we're putting our money into as a society to try to feed people who have, on assistance for food. A lot around corn, like high fructose corn syrup, for example. A lot around carbs, different things that make it hard for people to say, folks who have diabetes and maybe are getting public assistance with their food, it can be hard for them. Sodas, energy drinks, different desserts, this kind of thing. So it just gives you an idea that a lot of it's grain-based, a lot of it, it tends to just not be all that healthy, and that's a little bit problematic. Which brings me to the idea of fried bread. I know you guys have fried bread up here too. It's not just Navajo fried bread. But I grew up on the Navajo reservation. It's Navajo fried bread, and my mom used to cook it. She's not native. We're not native, but that's where we grew up. So for a couple years. And so Navajo fried bread actually came out of, it's not a traditional food. It's actually less than 150 years old, okay? It came out of this camp that was formed for to displace the Navajo all into one, like kind of in the Indian Wars of the late 1800s, where everyone was rounded up and kind of displaced up to like 400 or 500 miles. They were eventually let go, and a lot of them made it back to their historical places. But when they were in these camps, there was very little to eat. They were given very little. So it was like, I don't know, what was there? Does anybody have any ideas of what was available? What's that?
Beans, lard, and flour.
Beans, lard, and flour. Maybe some dairy, like some sort of, there was a cow that somebody milked and they could have some milk or something like that. So really limited in terms of what was there, and it's the type of thing that they make the Navajo fried bread out of. So this is kind of a historical picture of a Navajo woman making fried bread. I've actually been to a sheep camp that actually looked a lot like this. It was very interesting to see, where they didn't have kitchen facilities. They just camp out, and she made fried bread there around the fire. And then this is kind of what it's turned into, where folks you can get fried bread a lot of places, and it tastes really good. So I can see why people eat it. So when we talk about, back to what we're talking about, that's kind of a sideline into, to make it interesting for global health kind of thing. But so what are we doing about food insecurity? So we've just started a partnership to do this thing called Screen and Intervene. Okay, this comes out of the Montana Food Coalition, something like that. I should know the name right off the top of my head. But it's two questions that were asked. They came to us and said, would you start doing this screening? And I think we're the first place in the state that started doing it. And it's kind of two simple questions. In the past 12 months, did you worry about the food running out? And did the food not last? And so we applied that. We talked about it, and we do a lot of screening questions at Partnership. We screen for depression. We screen for a lot of different things. And so, boy, it felt like a lot to add one more screening, you know? And, but really, when you think about it, with the frequency of food insecurity, it maybe should be something that we do more frequently. But the intakes can take a long time, and we screen for a lot of different things. So what we decided to do was target it for abnormal weight adults, abnormal weight elders, okay? So 65 and older who were abnormal weight, and prenatal patients. So all of the prenatal patients got screened. So this is what we did. This is just a trial that we did. We've done just for a few months, and this is what we've done so far. So prenatal intake, I think it was just a couple, for only 16 patients, it was just a couple of months. 7 of those 16 screened positive for a food worry or running out of food. So pretty high percentage of prenatal patients with food insecurity in our population. We have a community health population. Most of our pregnant patients are on Medicaid, come to us without insurance. We help them get on Medicaid. Pretty high percentage though. Elderly with a BMI of less than 22. This is actually a normal BMI of 22. Abnormal is 19 or less, but whoever was doing this picked that as the number to go. I didn't have a part in it, but let's go, let's do it. So it's actually kind of a mix of lower risk and higher risk sort of thing. So it's kind of mixed, but we did it in it's actually 3 sites, 2 counties. So up in Sealy, here in Missoula, and in Superior in Mineral County. So we talked about pretty high percentage of the people who were worried that food would run out, almost all of them knew about Meals on Wheels, but actually really relatively small percent of them actually got their food from Meals on Wheels. And through this intervention, we got a lot more people onto Meals on Wheels, particularly over in Superior or Mineral County. And then who had used the Missoula Food Bank, and about a third of them had. So that's a little bit about food insecurity, kind of what we've done about it so far. We're trying to employ this screen and intervene. We're sharing it kind of on a state level to, it's kind of flawed what we've done, but it does give you an idea that there's a lot of food insecurity here in Montana, particularly in a community health center population. So I think I want to end by just helping you all see what you can do. I've kind of done my part by trying to share with you all that this is a problem. Homelessness and food insecurity is a big problem. And I think even if you just appreciate that and maybe look at somebody different, have a different attitude, I think that that's pretty good. I do think that there's some really great volunteer opportunities, like particularly for college students who have an interest in health careers. I think it's the experiences that help you find your way. I think what you learn in a class is interesting, it gets you motivated, but trying to find a place to volunteer, I think, can make a big difference. And there's, the Missoula Food Bank, there's 3 different food banks and pantries. Some of them are religiously oriented. I didn't put their names all here, but there's actually a lot of opportunities to get involved with helping people get access to food that I think is pretty cool. And then the Pavarella Center for the Homeless, I think, is a kind of a key place where people get a lot of their resources. They take a lot of students. We had kind of a family friend who was a social worker who got a really great exposure there to some of the work they do, Salvation Army, and then Partnership Health Center, where I work. So I guess with that, I think that I'm done, but I'd be happy to answer any questions people have. Thank you for your attention. I appreciate it. You had a question there?
Yeah, I've noticed that many people don't have food staples in their homes, nor seemingly know how to cook. Or maybe in some cases don't have the utensils or other things necessary to cook the meals. But I was surprised to see how few people really know how to prepare food from basic ingredients.
Mm-hmm. Yeah, well, that's an interesting observation that I think is really, really important. I think that we've gotten out of practice, and we've lost some of our traditions around cooking and being crafty about how we cook. I'm actually somebody, I can go to the refrigerator, everybody else thinks it's empty, and I can get a meal out of there. But a lot of people don't have that kind of, they're not crafty like that. And I think that there are some skills around food preparation, like what's healthy, what's not. I mean, that's what a lot of what we teach in a medical setting around diabetes or nutrition education. But I think also just, the extent to which the extent to which fast food is seemingly cheaper than cooking for yourself creates this kind of challenge that I think you nicely pointed out. Yeah.
I had a question about substance abuse. You had a slide about homelessness and substance abuse, and it said something about 30 to 50%. I'm not sure what you meant by that. Did you mean that of the homeless people, 30 to 50% are alcoholics or substances? Mm-hmm. And then I've heard locally that the Pavarella Center will not admit someone that they feel has been using alcohol. Mm-hmm. So I've heard that part of the problem with the people that are sleeping outdoors is that they're also involved in substance abuse and can't go into the centers or the shelters. Is that accurate? You think that number?
Yeah. So the number is, it's not my number. It's, right. I'm not really an expert.
I was thinking about the fellow that was found in his sleeping bag recently.
Yeah.
passed away if he was maybe
Yeah.
involved in alcohol or substances and couldn't. My son lives in the community, and his wife, and they're younger folks, and they're out at night, and they've met people on the street that are begging. They say they have no money to stay anywhere. And my son would say to them, why don't you go to the Poverella?
Yeah.
But they've been drinking and they can't go.
Yeah. Yeah.
So,
Yeah, it's true that they have that rule. That is a rule of the Poverello. I think the reasons for them instituting the rule are good.
I'm not saying there's anything wrong with it.
Yeah, to protect the safety of the people who are there.
Sure.
It can become very chaotic even without young people, you know. And then people's personal safety is affected if people have been drinking. I also like the rule as kind of helping people understand the boundary of, I think it's probably helpful for some people who are maybe closer to making some of the changes that they need to make to get toward a kind of permanent housing situation. That might just be my bias in getting back to that slide of the myths of homelessness, but because we are all susceptible to it. But you know, it's hard because there's so many predisposing factors. There's so many issues that people don't really control. But then there's also personal accountability that people can control. So you want to try to be supportive of people in the ways where they can't control it. Like they really don't have the say, and they're more maybe a victim or something. But then where there's certain places to maybe put a boundary that can help people make a wiser choice. I support those.
So you touched on this big plan is ending homelessness. And I like the slide that showed all the years that this is supposed to happen. My question is though, are there goals and measures for preventing it to begin with? Starting with younger ages, because you know a lot of kids when they take these surveys like YRBS when they're in high school and whatnot, they might be couch surfing and technically that's homeless, but they don't really recognize that. So how do you bridge that gap before them tipping off into complete homelessness and into later adulthood?
Yeah, I mean, that's a great point. It is such a multifactorial problem. There are so many different issues. You know, like a certain person's level of education is very predictive. You know, the different role models. I think Narissa talked about the adverse childhood experiences and how that really just lays the groundwork for a lot of these things before, you know, any interventions are really possible. Gosh, there's a lot of good points there. So I guess to get at your specific question in terms of trying to avoid homelessness, I think trying to have good access to the social services that are available. So trying to help recognize, well, even before someone becomes homeless, trying to have supportive programs around food stamps or other ways to help people meet their needs. There's a lot in this county about housing assistance, particularly with the high rents that we have in this county. We need that a lot. So I think there are some things there about prevention that's part of the approach to try to keep people in stable housing, try to respond quickly if they do lose their place, and then if they are out there for longer, trying to help pick things up, get it together to get people back into stable housing, back to employment, those sorts of things. So I think it's on all those parts. It's prevention, early intervention. It's dealing with trying to help reverse and end chronic homelessness as well. Up in the back.
Just curious, do you know maybe the average number of years that a homeless person spends being homeless before they either get out or die? I mean, is it when you enter in, you're there for life? Or, how
So
long are you homeless?
I think this one slide, speaks to a lot, the answer to this question. Are you guys getting sick yet? Oh, there it was. Is that it? No. Oh, why was I thinking about it? I lost it. Sorry, I distracted myself. That's a bad sign. I'll just leave it here because this. Oh no, no, this is the idea. So when you talk about like maybe what you were getting at is like the chronically homeless person, somebody who's on the street for more than 30 days at a time, 60 days at a time, 90 days at a time. You're talking about a really small sliver of folks with a problem. And it's some of these other areas where people are homeless for a night or a week. If something's fallen through and they need to get into another place and they're trying to make it to that next place. So I think that maybe is part of it. One of the things I said early on is that it's too expensive to try to solve this problem. And I think, just the opposite. We actually save money when we address this problem. So some of the studies around this permanent stable housing intervention that's been started since 2010 is that it's been effective, somewhat effective in decreasing rates of homelessness. It has been effective in decreasing rates of homelessness, even if it's not to the extent that we hoped for. And it actually significantly decreased costs of healthcare for the populations that they were able to stabilize. So I don't think I answered your question in terms of the amount of time, except to say that in general, people aren't homeless for as long as we think. So it's not years, it's more like months is a long time, and much more typical is shorter amounts of time, or folks who, if you broaden the definition of homeless, never go without shelter, but really have a lot of insecurity and issues that would affect their health. And so I think we need to be sensitive to that, particularly as a society and in healthcare, as we help these patients, help these folks. Yeah.
Does a significant portion of the homeless people have a history of being convicted of crimes and maybe having difficulties finding a home because of their criminal history?
Mm-hmm. Yeah, that's a major problem with housing for folks. And I know that there's some local efforts to try to aid people in their transition from detention. Like there's pre-release, so people are in the Department of Corrections and they get moved to pre-release, which is kind of this supervised setting where they have to follow a lot of rules. They get a job, they start kind of towards stabilization, and a lot of supportive services there for them to get to housing. So yeah, that's a major issue, and there's a lot being done to try to address that. So, folks who have had legal problems, folks who have been, in the armed forces, those are kind of two special areas where there's a lot of resources being aimed right now. All right, thanks a lot for staying and coming. Wish you well. Thank you.